Hey guys, Z-Dog. I got Jay Bhattacharya here, Dr. Jay Bhattacharya. He is a professor of medicine at Stanford, a health policy guy, health economist, and he's been on the show before. You may know him from such hits as a lot of stuff during COVID. Welcome back, Jay. Why am I spending all this time introducing you? People know who you are.
It's nice to see you back. Yep.
Dude, it's been, months since we had you on the show.
It feels like it's been too long.
Yeah, it's like a whole pandemic between us, man. Now, Jay, the reason we wanted to reconnect is there's so much stuff happening in the pandemic news. And notice I distinguish between the news and the public messaging and what's actually maybe happening in the world, what's happening in scientific discourse. You've been very vocal in the side of the science that questions, that says, you know what, is closing down the economy the right answer to this? Is, putting masks on young children the right answer to this? Are vaccine passports a good idea? Is a broad approach to this a good idea versus a targeted approach? And you were one of the co-authors of the Great Barrington Declaration, which just saying that aloud is going to get me demonetized and canceled.
Oh dear, I'm very sorry.
Yeah, thank you. You've cost me tens of dollars. So I think we can start by saying, first of all, you've been busy, but what is the main concern you have right now sort of in this whole?
I mean, I think that the central problem right now, I think, is the fear that people still feel about COVID, even after the vaccination effort has been actually in many ways in the U.S. quite successful. I think that we are so used to this fear that we've lived under for a year that we don't know how to get out of it. So you can see this when people that are vaccinated, they still are wearing them. My mom, okay, she's 80. She got the vaccine. She got the second vaccine. It's been a month and some since she got the vaccines. And she tells me she's so used to wearing the mask that she still wears it inside when there's no one there because she's just used to it. And there's still this fear. How do we decondition that?
Well, and then the question would be, and this is common. We're seeing this sort of pall of conditioned fear, and it's taken about a year of conditioning. So now, walking outside with a mask is terrifying to a lot of people, even after vaccination. Now, you and I are both vaccinated. Mm-hmm. We shook hands. We don't wear masks. We're about 3 feet apart from each other, and in the early days of the pandemic, that would have gotten us both hung. But now I can say with confidence, because I've looked at the data, our chances of giving each other COVID are pretty much zero. Yeah. So how do we decondition it? And in the setting of continued uncertainty. So I think the part of the problem is, let's forget about the press and how they portray it in the public health apparatus, but just the general uncertainty. So if Michigan's cases are surging in light of a lot of vaccination going on there, how do you think about that?
Yeah, I mean, I think the key thing is we look at cases, we say, oh my gosh, deaths are coming. But I think if the vaccination campaign has been successful, you'll have a decoupling of the deaths and the cases. Mm. We should no longer look at, in places that have been vaccinated, where the older population is vaccinated appropriately, we should no longer look at cases as a marker of doom to come. Mm. Right? Because the vaccine is incredibly effective. There's just good news about we can talk about the Johnson & Johnson bit in a bit, but on the whole, the vaccine it's an incredible achievement, and in many ways has defanged the epidemic. It's taken away the specter of death and hospitalization that comes with the disease for the older population, to the extent that the older population is vaccinated. And so the worry that we have over running hospital systems, large numbers of people dying from getting COVID, we should stop thinking that way when we see cases. The key question is still, just like it was before, actually, in some sense, who's getting these cases? And if it's the older population, we should be very concerned. If it's younger population, I mean, it's COVID. It's not good, but it's not quite the same thing.
Yeah. So why do we keep hearing then about these new variants affecting young people more, or concerns about mortality in the new case surges in a way that it is younger people maybe? Why are we still hearing about this when I have not seen good evidence that variants are more deadly or so on?
Yeah, I mean, I think it's partly the fear, right? I think it's hard to let go of that. You've lived for a full year under it. It's hard to let go. I mean, in some ways you can understand it, right? It's like been conditioned to be careful, and when the danger is gone, we're still careful.
Do you think the danger is gone? Where are we in that?
I mean, I think we're close. I think we're very, very close to that. Yeah. I think that in many places it is gone. Just paid at a high cost, of course.
Right.
But it's very close to that.
So Israel, with 50% odd vaccination, we're seeing cases decline, deaths decline, hospitalizations decline.
I mean, for the most part, it looks like. I mean, there's still some cases. I mean, it's an endemic disease. It's not ever going to get to zero. I think that's a fantasy. And so it will be with us essentially for the rest of time. I think, just like the other coronaviruses are.
Right.
And we just have to make sure we understand who's at risk and really, I mean, I think start to lift the lockdowns, because the lockdown has been so harmful. Yeah. It's continuing to be harmful. My kids still aren't in school. I think that we're going to need to have a conversation about how to live with COVID. Right. Without this thinking like it's the worst danger on the face of the earth.
Well, so one of your things, Jay, that I thought was really, it was controversial, right? But also, in retrospect, probably correct, which is the seroprevalence study that you did early on got a lot of criticism, et cetera, with Ioannidis and how do you say John's last name again?
That's it. You got it.
I nailed it finally. And you guys had estimated the infection fatality rate somewhere in the 0.2.
Yeah, about 0.2. Yeah.
0.2. Where did it settle out, do you think?
0.2. Yeah.
So I think.
I mean, this is worldwide. This is one of these fallacies like the people sometimes have in their head. So like, there isn't a single seroprevalence number.
Right.
I'm sorry. There isn't a single infection fatality rate number.
Right.
There's a range of them. Some places had it worse and some places had it better. And for some places we had it worse for reasons we can understand, right? You had an older population. Its hospital systems didn't do well in managing the patients. It's early in the epidemic and we're killing patients with ventilators or something, right? So you can have a high infection fatality rate in that setting, and in other settings did quite well. Like, so for instance, and again, for reasons we understand, right? You just, they manage the patients better. We have better inpatient, outpatient treatments. We're managing patients better. And so you have a lower seroprevalence, or you have a younger population.
Infection fatality rate,
is low. You get I keep making that mistake.
You're by the transitive property of seroprevalence to IFR.
I think it's like one over the other, one divide, whatever. You get the thing, yep.
Exactly.
So in any case, so the key thing is that there's this distribution. And some places they did well when we don't understand why, like Japan. The infection fatality rate number there is quite low, even though they have an old population. So we have this but the point is that there's this massive distribution. The median estimate I think is 0.2 worldwide, and I think the U.S. is probably higher because New York and New Jersey got hit hard early and didn't do well. But I mean, Santa Clara County, April last year, it was 0.2. And in fact, there was another study done that included the Bay Area I think it was like ESRD patients, seroprevalence, I think in July or August, and it was 0.2 in Santa Clara County, or in the Bay Area, again, and later. So I think there's a distribution. I think we got that number right. Yeah. In April.
And so that tells you something too. It says that, okay, there's a fatality figure that's roughly, if we believe the flu IFR, which I'm not sure how accurate this number is. So they're not.
I have no idea what the IFR is for the flu.
Yeah. I don't think anybody does.
Yeah.
Yeah. We throw around 0.1, right?
Yeah. But I don't know if it's right.
Yeah. Do you think it's lower or higher?
I have no idea.
No clue,
I don't
right?
know.
Yeah.
We don't actually, now that I've looked at it, we don't actually have very good seroprevalence estimates on the flu either, season to season.
Yeah. So incomplete data. Yeah. Because, the whole comparison with flu draws all kinds of knives out.
But I will say the one thing about the flu that we do know quite well relative to COVID is the age gradient. The age gradient of infection fatality for COVID is way steeper than it is for the flu. Right, so that older people are much, much more likely to die from COVID versus young people dying from COVID. Whereas the flu, the age gradient still is upward sloping, but not as steep.
And I think this is a central piece to your whole approach of looking at this pandemic, which is a harm reduction approach across all sectors. So it's not just how many people are in hospitals, how many lives are you saving, you're looking at across everything. How many lives are you saving across a population? What happens when kids are not in school? What happens when you destroy economic livelihood? Because as we talked about last time, health is wealth. They are to some degree interchangeable.
Yeah. Well, I don't see any other moral approach to this, right? What is a lockdown? A lockdown is essentially an attempt to reduce the level of human connection, human contact. Well, what does that mean? It means essentially an undoing of a million things, that small things and big things that give our life meaning and purpose, that keep us healthy and strong, keep us sort of going. If you think about what the lockdown effects are, you can't simply just look at what affected on COVID. You have to think about what those kinds of effects are on every aspect of human life. And unfortunately, I think it's even worse than that. It's the effects, the negative effects of lockdown are worse on the poor than they are on the rich. The rich, we can afford to like sit in Zoom and have people deliver stuff to us. But if you're, an Indian, a coconut water seller in Mumbai, and the country's locked down, you're forced to walk, 100 miles to go home, and your livelihood's gone. I mean, you're going to get hit hard. And there's now like actually good data on this. There was a fantastic paper published out of a group in Berkeley that surveyed tens of thousands of poor people in countries in Africa and Asia, and they found enormous increases in poverty and enormous increases in food insecurity. The early predictions about that are coming true, about the lockdown effects on poor countries.
I'm going to say something that I think is we'll see what people think of this, but I think it's true. And I think you have to speak the truth as you know it. I think that there's a rich class of people, especially in the United States, that can absolutely not just afford, but thrive in a world where the in-person stuff is shut down for the majority of people. They're cheating often, they're having family gatherings, and they are able to make a living, actually a better living. In fact, the wealth inequality has increased during the pandemic. And they're the loudest vocalist folks when it comes to, hey, we should stay home and save every single life possible at whatever cost. What about the cost of lives and sanity and futures for children? The wealth disparity.
Yeah, I mean, I think the lockdowns have worked for one group of people. It's exactly the group of people you said, right? So I'll give you one statistic, right? If you look at LA County, the data in LA County, they have on the LA County site, they have age-adjusted mortality by zip code income. So like Beverly Hills, less than 10% poverty, like pretty low poverty rate there. It has 1/3 the COVID-related mortality, age-adjusted, relative to the poorest parts of LA. It's 1/3, right? So the poor, who has borne the burden of this epidemic? It's the poor, especially in the lockdown. Actually, funny enough, in Florida, which didn't lock down, you have much more equal outcomes across income level.
Interesting. So rich and poor are equally affected.
Yes. Yeah. And the age-adjusted mortality rate is actually lower in Florida than it is in California.
Age-adjusted.
Yes, because Florida is one of the oldest, and California is one of the youngest.
So, and that makes me ask about, because again, you what you're trying to do, Jay, and I think people misunderstand you. You've been vilified because of any association with Great Barrington, which was considered a taboo violation of the dogma that there's no such thing as targeted interventions for a pandemic because young people walk around spreading disease. But I think your whole piece is that these approaches that have been very heavy-handed are not equitable. They're not compassionate. And that's what drives you to go and continue to talk about it at great, personal expense.
I think the lockdowns have hurt basically every poor person on the face of the earth.
Yeah.
I think what we did is immoral. That is what's driven me to speak up, because I think there needs to be some voice speaking about that. And I think we could have done better, right? I think the reaction to the Great Barrington Declaration was, oh no, we can't protect the vulnerable. The only way to protect the vulnerable, the old, is by lockdown. Well, we see the lockdown hasn't protected the vulnerable. We fail, like 600,000 deaths. I mean, that's like, we failed to protect the vulnerable. We have the lockdown arms in place that continue to lock down. Instead of engaging and saying, well, how can we protect them? Well, that's what I expected to happen. I expect the public health community to work together and say, well, okay, we haven't done a good job protecting nursing homes. We haven't done a good job protecting older people living in the community in multi-generational homes. We haven't done a good job protecting older workers. What kinds of policies can we adopt that would protect older workers? Let's give them paid sick leave.
Paid sick leave.
Yeah, I mean, let's multi-generational homes. I was on it's funny, like I was on one of the things we did in the Great Barrington Declaration said, well, why don't we make hotel rooms available to older people living in multi-generational homes? So some, their 20-year-old, grandson comes home and says, oh, I might have been exposed. Let's have a hotel room available for the older person so that while you check to make sure it's negative, just like we do with hotels for homeless people, which is, I think, a good idea.
Yeah.
But the reaction, I actually was on a TV show with John Barry, who wrote this fantastic book about the 1918 flu. But his reaction to that idea was, oh, why do you want concentration camps for old people? I mean, what nonsense, right? Like, I instead of trying to constructively engage to try to protect old people, we just decided that we can't do it.
Yeah. And I think that was the biggest criticism. And then there's other more insidious stuff happening, which is, first of all, why did you even feel the need to do such a thing? Because I did a video where it's like, why are we even, because we had the dual declarations, right? You had the Great Barrington and who was the other guys?
Jon Snow, yeah.
Yeah, Jon Snow. I mean, what is this? Game of Thrones? Like, are you guys going to take the black? It's like whoever loses has to take the black and go north of the wall.
The irony is Jon Snow, of course, is the famous sort of founder of epidemiology. He found out that cholera was coming from this, like,
the pump.
The Broad Street pump, right? So, the irony is Jon Snow argued for focused protection. He said, let's not have like a broad lockdown of London. Let's just fix the pump.
Where
that's infected.
Right. So that's kind of ironic. But why did you guys actually feel the need to do that? Because it's an unusual approach.
Yeah. So I think we're seeing a few things at the time. One is that there was basically no one really arguing for this. I think a lot of epidemiologists, a lot of folks were uncomfortable with the lockdown approach, but very scared to voice their opposition to it. Mm. And this focused protection idea, it's not a new idea. It was old as the hills. It's still as old as the hills. It's what we used to address many other epidemics very effectively. Mm. Mm. So there's two things going on. One is we wanted the policy to change to protect the older population, and we needed to give voice to that. The other thing is we wanted to give protection to other scientists who were afraid to speak up at the same around this. And I think in some sense we succeeded at that. Like you started to see after the Great Barrington Declaration more and more dissent. Mm. I think that's one of the scariest things about the epidemic actually has been this silencing of dissenting voices within the pandemic.
And this is important because if you believe the opposing side on this on Twitter, which is the majority of people who are vocal on Twitter.
Yeah, but not the majority, I don't think, of scientists, actually.
I agree with you because when they talk to me, they're like, well, we can't say this because we're going to get,
killed,
deplatformed. Yeah. What they're saying is, no, but there is consensus. And this is not consensus. For example, I'll just list off things for which they say there is consensus. Now, I don't know whether these things work or not. I'm going to say what they are. Masks for everybody. Closing restaurants, bars, schools, contact tracing. What else is dogma? Let's say
mass asymptomatic testing.
Mass asymptomatic testing. That's a great one. What else? What else am I missing?
Oh, let's not focus on the failure, shall we? I mean, I think that's. I think I've been trying to make sense of this. And I want to give folks on the who disagree with me their due, right? Because I do think there is a point to this, and like what So why this reaction, this sort of frankly overreaction to a plan that is again as old as the hills, like the Great Barrington Plan. So I think there's two norms that are competing with one another, and in one norm you have the public health. Right, in public health, you have to have basically some somewhat unified message, right? I mean, you have to say like, this sort of if you don't have that unified message, it can't be effective.
It's very tough. The public doesn't get the nuance and so on.
Yeah, and you're trying to communicate in a mass way. You're trying to say, you're trying to give as simple a message as can, as accurately as possible, that's consistent with the science, to get people to act a certain way. I mean, it is essentially a mechanism of population control, but a benevolent one because you're trying to get people to act for their own health.
Right. You're shaping a system so people will walk along a path that makes some sense, that's
Correct.
hopefully proven by data.
Right. And so their dissent is dangerous.
Right.
Right. Their dissent is it's edgy. You're like you're cutting against what the public, you're sort of there's a sense of solidarity that you're cutting against. I think that's the root of the reaction of the Great Barrington Declaration was this public health norm has been violated.
Yeah.
And obviously it was because that's the point, right? The reason why is there's a second norm, and I think a more important one.
And by the way, you said the word dangerous. You said it's dangerous in public health.
I've gotten that 500 million times.
Yeah, because you've been called dangerous. Yeah. I've been called dangerous. I've had people text me saying, your skepticism of cloth masks early on was dangerous. Okay, so show me the data.
You were completely right. But whatever. Look, I think, so that's one norm, right? Mm-hmm. One norm is this public health norm. The other norm is the norm of science. Mm. And in science, not permitting dissent is itself dangerous.
It is the worst anathema to the scientific approach and method.
Yeah. You have otherwise, how are you going to discover things unless somebody says, no, I don't think you're right. And then we have disagree. It's a dialectical process. That's what science is, right? Like you think A, I think B, we disagree. We come up with C, and if C is true, then you're right, and C is false, I'm right. So we do an experiment. C turns out to be true, you're right, and I'm saying, oh, damn it. And then the next time we go on, and I say, no, A prime, and now we're going to have another fight over A and A prime, right? I mean, it's just you have to have this sort of freedom to say B when you say A in science, or else science cannot advance.
Can't work.
And the public health norm is premised on a consensus, a well-known consensus on a deep body of science, or else it's immoral, right? You don't use public health as a mechanism of population control unless you have this deep body of science, this truth that really most people, we've now gone down this dialectical path and have arrived at something where we're pretty sure is right.
It's interesting that you mentioned public health and population control. Now that's going to trigger like a lot of people. Well, he's calling us population control. No, what you're saying is it's benevolent. I mean, you're asking a population to do something.
It's completely appropriate, right?
Right.
When you have a consensus that really is solidly scientifically based,
right?
So what's good?
Childhood vaccinations.
Exactly.
Yeah.
MMR vaccine is a godsend, right? And there's an enormous body of evidence that suggests it's a godsend,
right? And
so the public health norm of not dissenting around that is very much justified. Yeah. Now there could be. I don't think so, but it's possible. It's science. There could be some piece of evidence that comes up that undermines that sort of consensus in science. In which case, the public health messaging ought to change.
Right. You update your priors and you change the messaging.
Right.
Yeah.
And so, but the science is the consensus in science is the moral backing for the sense that there's danger in dissent in the public health norm.
Yeah. And that makes sense. And one interesting thing that I follow up on that, when you talk about public health being a kind of a population control, I don't know if you saw the Mercury News piece here in the Bay Area about they made public a Slack communication channel among all the public health officials here in the Bay.
I didn't see that. Actually.
It was fascinating. So Sarah Cody in Santa Clara and Scott Morrow here in San Mateo and Erica Pan.
I would love to see a discussion between them. Actually.
It's fascinating because they were struggling and wrestling with this was early in the pandemic, this new authority that had been given to them to control people's behavior. Mm-hmm. Like we could shut down restaurants, we could shut down schools, we could shut down all non-essential businesses. Like this is crazy. And they struggled with that. And at some point, Scott Morrow in San Mateo asks, so we're saying gatherings of 30 people outside is good. What's that based on? And they're like, well, we have to put a number on it. So we're going to put a number on it. I mean, it was chaos. And so I think this idea that this is some infallible science that we're then communicating en masse is not true. They make compromises. They have questioning it should not be.
Yeah. Well, again, the moral basis of that sense that there's dissent is dangerous in public health. The moral basis of that is true consensus in science. But you have a new virus. You have all kinds of novel interventions. There is no consensus in science, and I mean, especially last March, there was no consensus in science. I don't think now. I think Just look at is it the CDC changed from 6 foot distancing to 3 in schools? I mean, that means 3 feet was okay all the way across. I mean, the plexiglass is no longer necessary. I've sort of lost track. Like,
there's a million of them. Yeah.
I think science is changing on this because it's a new thing, and we're learning new things all the time.
And you know what's crazy? All this year of research, we've learned a little bit, not enough, because I don't think we've questioned hard enough. We haven't done real science hard enough. We haven't done cluster randomized controlled trials of masks.
Let's go back to the seroprevalence studies. Why was it like my group and a couple other groups doing the seroprevalence? Why wasn't it the CDC systematically tracking this, or still systematically tracking it, frankly?
Right. It's like an operative central question.
Yeah.
And I think the other operative thing that you said is this is a gradient disease. So elders, people with chronic disease.
I mean, that's one of the reasons actually for the policy argument for the GBD, for the Great Barrington Declaration. The policy argument is that on many, many sort of different questions, it doesn't matter what the answer to them are. The focus protection idea is still the optimal policy. It's harm reduction, right? It's still the right policy. If the IFR is really high on average, as long as there's this gradient, you still do focus protection. Right. For instance, so it's invariant. The right policy option is invariant to many of these uncertainties in the science.
Right. So in other words, it allows for changes in data because there's a broad applicability to that approach.
Right.
And the question is, again, they'll say, well, what about the feasibility of it and so on? And now what they're doing is, I think there's this mission creep that's happening in public health, or maybe it's not public health. Maybe it's just
it's a fear.
A fear. And they're saying, well, but now younger kids with these new variants, we don't know, it's a little more infectious. Now school age kids, what if they get really sick? And, even though this thing has killed less than, or about as many as flu would kill in a normal year in kids, hardly any. I mean, again, that's not compassionate to the people who've lost children, right? But understanding from a population standpoint, if we keep creeping it, we will cause inadvertent harm that you will recognize. You'll go, well, but then so we're going to keep schools closed and do distance learning that's been harmful for the majority of especially poor children, right? And the only other thing I want to say about this is, when we talk about lockdowns, that's not one thing. We don't even know what that means. Like, when you say lockdown, what are you talking about?
Well, it's a whole suite of policies. And obviously you're right. There's a range, right? So school closures, business closures, church, synagogue, mosque closures. Those are like one set of because stay-at-home policies is probably the sort of the furthest along that range. Restrictions on mass gatherings, recommendations that you shouldn't go over to dinner with other people's house even though they've been vaccinated. I mean, these are all like forms of law. Anything that's aimed at prohibiting human contact.
Yeah.
Is a form of a lockdown
policy. So then let's segue. That's a nice segue into vaccine messaging currently. All right. As you mentioned, and I continue to mention, these are incredibly effective, almost miraculously effective.
They are amazing.
Particularly the mRNA.
Can I say one? Sometimes people will ask me what I got wrong. I'll tell you, my mea culpa. I did not anticipate in March of last year that it was at all possible to produce an effective vaccine in the time it did. It's absolutely true. That's
such a politically awesome answer. Is that, what did I get wrong? Why I didn't predict the miracle of vaccines?
I did not, but that's just honestly, actually, I was trying to think whether that would have affected my thinking in March.
Right. Oh, well, let's dig into that. If you knew that this vaccine was coming, would you have been more amenable to saying, well, then lock everyone down until we get there?
Yeah. So I think, I think that's the obvious, like I know the vaccine's coming day after tomorrow.
Right.
Fine.
Right.
The vaccine coming in 10 months, I still think the lockdown is the wrong answer. Right. You still do focus protection in the meantime.
Because of the ancillary harm.
Yeah, because of the ancillary harm. The lockdown harms are absolutely enormous, and you cannot ignore that in the policy calculus. The other thing is the inequality of it, right? So for 10 months, rich people can't afford to do this.
Yeah.
Poor people cannot.
Yeah.
And you can't blame poor people for that. It's just a fact of life.
Yeah.
And you don't design policy around asking people to do the impossible, which is essentially a 10-month lockdown policy.
Come on, dude. They got $1,400. That's the equivalent of let them have cake.
Right.
Yeah.
Oh my God, it's even worse, right?
It's worse, yeah.
And that caused a huge revolution in France, if I understand it correctly.
I believe that heads were lost. Decapitations and defenestrations, people thrown out of windows.
But so I think the answer still is focus protection if it's 10 months. If it's 2 weeks, then it's different.
Yeah, and the other, the other issue with that, then let's dig into that a little more. We now have vaccines. So I think people would say, well, now there is a finish point. Let's keep everybody under wraps and do everything we've met. That's the double masking thing and all of this and these variants. Let's get as safe as we can until we can get everyone vaccinated. What do you think of that?
It's the same exact problem, right? There's more actually. So first is a failure of focus protection. It's continuing the lockdown harms, right? Schools still are not open in California. Poor children are the ones that are suffering the most. And not only that,
Poor children. There we go.
My OCD, the mic was a little crooked. I had to do something. I had to make an intervention. Focused microphone intervention, people.
Oh, dear.
Anyways,
Oh my God.
So back to what you were saying.
I mean, this is like you're inviting like amateurs to your professional podcast. I don't know what you expected to happen.
You're a pro, dude. I saw you on Dr. Drew.
Oh God,
I was on Dr. Drew too.
Okay, so you have these like you have this like situation where you have this fantastic vaccine, and you've sent this message that your life will not change even if you take it.
Yeah.
Are all surprised that people are saying, "What's the purpose of the vaccine? Is it any good?" I mean, it's the worst. It's the most anti-vax message I've seen in my life.
It's so anathema to actually having people get the vaccine. Like, look, you and I are both vaccinated. I mean, what kind of sense of liberation did you feel? I mean, and again, you're less worried about COVID.
I wasn't particularly worried personally about COVID because I've done the risk calculator. My risk was like 0.2. I mean, my IFR was 0.2. So I'm 50. My IFR is 0.2. Every 7 years of age, you double the IFR.
So you did your math.
Yeah.
See, mine
I'm
is
52 actually. So
old man.
I know.
I'm
Really.
going to be 48 this month. So that tells you what my risk is. But I also have 2 clotting alleles. So I have factor V Leiden and
so then
prothrombin.
you're going to be higher than me.
Exactly right. So that's why when I got the vaccine, I was like, oh, good. I am not going to die of a massive pulmonary embolism that's induced by COVID.
Right.
Not by the vaccine, which we'll talk about, but by COVID. So that the reason I felt relief with that vaccine is I knew that I could go back to doing a lot of things with other vaccinated people or people that are low risk because I'm a doctor and I've looked at the science.
Yeah.
If I listened to the public health apparatus, I would still be...
Well, they're aiming for zero risk in every activity or surrounding around COVID, while at the expense of all the other things in your life that are not around COVID.
Right.
It's just so it's irrational, right? It's monomaniacally focused on a single risk, minimization of a single risk. But if you do that, you're going to harm other things in your life that are probably more important to you.
Yeah. Yeah. And one thing I will say is this pandemic has been good in the sense that people are always talking about, we got to get back to normalcy. And I'm like, I don't know about y'all, but normalcy kind of sucked before. Like we have a broken way of doing things in the world. So hopefully when we get back, there will be a little bit of improvement in, we've had time to spend with our families a little bit. It's assuming we're rich and we're in the Zoom.
Yeah, I mean, I think there are some things that are good for the lockdown. I mean, like just like the if we actually can figure out a way to make work from remote work for many people, that's actually a good outcome, right?
It's pretty good, yeah.
So I mean, there's some potential. We should go back and look for lessons. Yeah. Because that's one of the things I'm going to be doing is trying to do research on the collateral effects of lockdown. I think that needs to be documented. And so if you go to a website, collateralglobal.org, there's a project I'm working on to try to start to document that.
Quantify that.
Yeah.
Well, so there's a little mixed information come out on that. So for example, suicide CDC reported we're actually down in 2020.
I saw that 4%, but on the other hand, suicidal ideation was up enormously, right? Up 25% in the 18 to 24 category last year.
Yeah, and I just interviewed a psychiatrist, Judd Brewer, who said his practice has been just overwhelmed.
Well, I mean, I think
anxiety.
there's this like mass anxiety. Everyone's felt it. I don't think anyone in the audience hasn't felt it to some extent or other. It's just
the social contagion. Right? Yeah,
and I think it's surprising that the suicide rate is about the same as it was.
Yeah.
But that shouldn't change how you think about that. I mean, we should start. We need good science on this. Is the point, right? We should like figure out what we should count the cost, right? And I think that's part of
what you're trying to do.
Yeah.
Yeah. So one thing I think I got wrong is I was thinking that there was some existing natural T cell immunity that would have caused cases to rise in young people in the winter, but not deaths. And then deaths rose. And I was like, well, I was not right about that.
Yeah, well, we have still failure to focus protection. Older people still got...
Older people still
It's
majority.
still 80% of the deaths are 65 and up in the U.S.
That's the statistic?
Yeah.
80%?
I think it's something or it could be 70 something.
It's high enough that if, like you said, a focus protection would have saved, if you could pull it off.
Yeah.
But concentration camps for old people, Jay.
What nonsense.
But I think it's that kind of like, it's almost an ad hominem to say something like that. Because the minute you start making references to Hitler, Nazis, and et cetera, you've already lost the argument.
There used to be a thing in the internet. As soon as the first person that makes the reference has lost the argument.
Has lost the argument.
Yeah.
It seems to happen routinely.
Yeah.
So I got the T cell thing is another interesting thing is now India is getting their second surge. And have you looked into this at all?
A little bit. I mean, it's still, the death rates are still incredibly low. The IFR is still incredibly low in India.
Yeah, just large numbers of people.
Yeah, large numbers of people. But I think what happened in India is the poor population was the first surge,
right,
and the rich population is the second surge
because they're opening up and they're
it's incredibly unequal in India.
Yeah,
right? The lockdowns were essentially. They couldn't enforce them in the poor population because you just would kill them.
Right.
And so it lasted for like 15 seconds.
Right.
And the disease spread everywhere. Right. I think there was a Mumbai survey in the Dharavi slums in I think it was like August or September of last year. And it was like 60% of the population. I mean, really, really high fraction of the population had antibodies.
Right.
I think, but that was the poor, right? And I think now we're seeing, I think a lot of poor countries, I think we're sort of seeing this residential, in poor countries, there's this like residential segregation between the rich and the poor, and one population is infected in one way and another population is infected in another way. That still needs to get sorted out, I think. I still haven't seen good stuff on that as yet, but that's I think the primary hypothesis.
Now we talk about vaccine messaging, the vaccine messaging around pausing Johnson & Johnson, pausing AstraZeneca for what we're seeing is these very rare clots, which I've done shows on. Roughly in America, we see so far about 1 in a million risk, typically younger women, age 18 to 48, 49.
Yeah.
Is pausing the vaccination campaign the correct approach?
No.
Why not?
I mean, it's again, another failure of public health messaging. If you want to create vaccine hesitancy, do what you just did. Tell people this is a dangerous vaccine on 1 in a million event.
But shouldn't we be hesitant? I mean, 1 in a million event?
I think the right thing to say is what we've found. We found that it'll be more than 1 in a million because but only a little bit because it's in the under 50 group, whatever that population size is, 1 in 700,000, whatever it is.
Right.
You have 1 in 700,000 risk of this blood clot. Here's your risk of COVID. Right. You can decide what's right for you.
Yeah.
If you're over 50, it's 0 in a million.
Yeah.
And here's your risk of COVID, which is really high if you were to get sick.
So it's easy.
Yeah. I mean, that kind of messaging would go along. People are not stupid about this. You just trust people to make the right choice by giving them information.
So heaven forbid, Jay, that we tell the truth. And honestly, I did a show exactly saying this yesterday, a live show where I said, let's talk about risk and COVID. And in Europe, AstraZeneca, they did a calculation, I think in Brits in their 20s, it's a 1 in 100,000 risk of an adverse event to that particular vaccine based on what and I didn't look into the primary data, but their risk of COVID ICU hospitalization varied. So it was anywhere between 0.9 in 100,000 and 6.8 in 100,000, depending on whether they were an essential worker, what their socioeconomic status was, what their zip code was, all the things you talked about. So making a decision depends on all those kind of things, right?
Yeah.
And now, and in the setting of having another vaccine too, the mRNA.
Well, we do this with other vaccines, right? So we risk stratify for MMR. We say, look, if you're 70, you don't need an MMR.
You don't need an MMR. Exactly. That makes sense. That makes perfect sense. It's just like, when I see a 90-year-old put on a statin, I always scratch my head a little bit, what quality of life you're saved are we doing?
Yeah. I mean, I think you can trust people to make the right decision if you give them good information. But whereas if you try to like just, I mean, this I really regret that they paused this vaccine. It just doesn't make sense based on the data, at least that they made public. I mean, of course, they could have some private data. I don't
That's
think,
right.
but
Yeah. We don't know. Yeah. My sources say that's not true, though. Yeah, that this is what's public is largely known. But I would say this because believe me, if I knew something that the public didn't know, it would infuse into my messaging.
Yeah,
because I don't care. I just want to tell the truth. And so that vaccine piece, I think we've bungled it because we throw this idea of variance in, and this is a partially public health apparatus, partially the press. But these new variants, for example, in Israel, there was a study that Israelis who were vaccinated with the mRNA vaccines were more likely to be infected with the South African variant. Did you look at this data?
Okay, so this is nonsense.
It's
right?
idiotic, yeah.
Right? So, like the key question is the same question: if I get the vaccine, am I protected against death and hospitalization from the variants or from whatever? And the answer is still yes. The answer is yes to that question. It's still protective against the outcome you just don't want.
Right.
So why on earth are we scaring people around some like uncertain thing? Much of which is produced based on these modeling studies that I just don't trust anymore.
Yeah.
So I think it's
they're bad studies.
I think as a general thing, we should be giving people information based on things that we know that they care about. We know they care about death, and we know they care about avoiding hospitalizations. We should all care about that, right? Mm-hmm. It makes sense. And the evidence that I've seen, anyways, to date about the variants is that the vaccines still protect against those bad outcomes.
That's right. That's my interpretation of the data as well. And what's interesting about this study that got pulled into the press by Reuters is that there was 5.9% of the infections in the vaccinated group in Israel were the South African variant. Much lower in the unvaccinated. Yeah. Duh. Yeah. That's from the New England Journal of Duh. Why is that? Because if you have a vaccine that's really good at stopping wild type virus, when you have a variant, the only way you're going to get infected is with a variant. Yeah. And then you're only going to be a case, not a fatality, not a hospitalization. And it's going to be higher than in the unvaccinated population that can just get infected with the garden
variant. Same thing with the fraction of the young people the fraction of cases among young people are increasing. I saw a New York Times article.
Yep, I saw that too.
As if we're like, we're vaccinating the old people. What did you expect to happen?
What's going to happen?
Yeah.
And
preferentially.
And people are appropriately going, hey, maybe we should start getting back to business here and hanging out with our friends and stuff. And they're young people and their risk is low. And, now they're not going to affect grandma because grandma's vaccinated, presuming that grandma is vaccinated.
Yeah.
Now, at this point, people should have the information to say, okay, I'm grandma. Well, I'm not going to get vaccinated.
I think 80% of the American population over 65 has been offered the vaccine.
Has been offered it.
Yeah, and I think it's on the order of 80% have got the first dose in. I mean, we've done an incredible job in vaccinating the old. We should be celebrating. Instead, we're like something on that order.
Would you call that targeted protection?
It's
Jay?
Focused protection. I didn't want to point it out, but in the vaccination campaign, we kind of adopted the Great Barrington Declaration, didn't we? And that's really good news.
Do you remember when Stanford residents threw a fit because,
But you know what? That was okay. You know why? Because they actually see old patients.
Yeah. No. I agree.
Yeah. So
I thought it was okay, but it was interesting because it was the young revolting and saying, why are these old attendings who don't even touch patients getting the first?
I was offered it actually when they made that mistake because I'm a professor at Stanford but I don't see patients.
Don't see patients, right?
And I sit alone in my freaking office. And there's no way in good conscience I could get before my mom. So I just waited until she got vaccinated before I got vaccinated.
Yeah. When I decided to do it, I was waiting too. When I decided to do it was when I heard that the place that was doing the vaccinations, 40% of people were refusing it, declining it, healthcare workers. And I was like, okay, I'm taking your shot.
You should take it,
I'm taking your shot.
Right.
Yeah, because I see guests. It's
a
responsibility.
You have risk factors. I mean, I think I don't want to be moral or moralistic about this. I think we all have our own sense of propriety about what's right. But I just couldn't do it until my mom was vaccinated.
I think that's fair. Yeah. And that reminds me, our messaging. Oh, you've had COVID. Get yourself vaccinated. Stat.
What on earth?
Why?
These are immunity deniers. That's who they are. They're
immunity deniers.
Yes.
Are you, man? You need another declaration. Just pick another city that'll get pissed off that you made a declaration about them. How about the Santa Cruz Declaration?
On that business of I think somewhere on the order of 120 to 170 million people in the U.S. have had COVID infections. Based on, depending on what you think the IFR is, you just take the number of deaths divided by your estimate of the IFR, and you get somewhere in that order.
Right.
Up to half of the American population's had COVID.
Right.
Or infected with COVID, right? So if that's true, why would we discriminate against them? Why would we tell them the thing that they had to suffer through to get to immunity counts for nothing? What is the reasoning there? I don't understand it.
The variance.
I see.
Yeah.
No, but natural immunity protects against the variants.
Yeah.
Again, with the severe disease from the variants, right?
Right.
So I think that, which is again the key thing.
Yeah, it's very perplexing. And I think a part of this that I think you've talked about or would like to talk about, because I would like to talk about it too, is how if we say this kind of thing, already YouTube has put a flag on this video, Facebook's put a flag on this video.
Well, this was the danger. I told you this might happen.
And I accept it. It was like you slapped me across the face with a white glove. D'Artagnan, I challenge you to have me on the show. I'm like, yeah, let's do this. I mean, what do I need $10 in ad revenue for? It's an interesting conversation because who's making those decisions as to what's misinformation, right? And I'll tell you, I mean, Vinay looked into Vinay Prasad is a mutual acquaintance. He's been on the show. He said he looked at it. It's people who have big Twitter presences who've already taken a stance on something. That's who they recruit to be their fact checkers, and of course they're going to disagree with Dr. Great Barrington and his crew.
I mean, I think again we can go back to our early part of this conversation. Like YouTube. I had a conversation with Florida Governor DeSantis.
How dare you? He's a Republican.
I mean, okay, there's a few of them, I guess. So you kind of still have to do public health there, right? The conversation, one of the topics of it was pretty wide ranging. It was on TV. It was on like the Florida TV channels, and then it was a pretty wide ranging conversation about COVID policy going forward, vaccinations and so on. And one of the questions that the Florida governor asked me was, should children wear masks? So I've looked into this, right? So you can read the CDC guidelines, you can read the World Health Organization guidelines. They disagree, right? So the CDC says mask over age 2. World Health Organization says mask over age 5. Right? If you read the reasoning, what the World Health Organization does a much better job with the reasoning than the CDC. But like what they say is there are lots of harms to children between 2 and 5 from masking. So the key developmental stages that might get missed, language acquisition, so on and so forth, right? And for over 6, there's still harm, right? Social and emotional development are harmed by masking, they say, or at least potentially.
I believe it, yeah.
But then
intuitively, but I don't have data.
Yeah, well, that's what they say. I mean, I believe it too. So I mean, I'm not a pediatrician, not a development expert, right? But it's consistent with what I learned in med school.
I stayed in a Holiday Inn Express yesterday.
Exactly.
I'm basically Piaget at this point.
Right. But in any case, I mean, there's some harms from it, right? On the other hand, what's the benefit?
The benefit, yeah.
The benefit is slowing spread of disease. Well, I mean, what's the literature say on this? This I actually have read a lot about. So like from the Iceland study from early in the epidemic, kids are very inefficient spreaders of the disease, just straight up. They're just for reasons we still don't fully understand. They may have high viral loads in their nose and they're still not spreading the damn disease, which is fantastic news, right? That we should act on. Right. Sweden, they've had children in school at age 1 to 15 and preschools for the whole epidemic without masks. And the teachers are at lower risk of bad COVID outcomes than the average of other professions.
So the children are protective in some way.
Yeah, and then no kids died either.
They're absorbing all the COVID and keeping it down low.
Yeah, I guess. I mean, I don't know what it is. Whatever it is, like these are facts that are in the scientific literature that suggest that kids are not a huge risk of disease spread. Yeah. That's just a fact.
It's been consistent,
right? And there's a ton of studies that now show this. The other thing is you ask a 2-year-old to wear a mask. I mean, I've had 2-year-olds. They're not. I mean, they're gonna. I mean, they don't. They're not going to wear a very effective. And even 11-year-olds. They're running around. They're not going to wear a mask effectively. Like you can't ask them to do that and judge them on the fact that they're being kids when you tell them to wear the mask and they don't wear the mask. They just are. They're not going to wear it right.
And they're masking kids during sporting events and things like that.
Yeah, and where people you have the down over the nose because you have to breathe.
Can't
I mean,
breathe,
it's just actually the World Health Organization is explicit about this. You shouldn't wear masks during exercise. Okay, so I'm looking at this. I've looked at this information. I do a very simple. I'm a health economist. I do a very simple cost benefit analysis. very little in the way of benefits and some costs.
Yeah. So why do it?
So I said, no, you shouldn't mask kids. For that, YouTube pulled the video down.
Really?
Yeah, that censored the whole video, the whole hour and a half conversation.
They pulled the whole thing down?
Yeah. And it was posted by some local news station. So they're like censoring the news. And then NBC wrote a story saying that it was effectively that it was good that they censored the whole conversation.
Of course NBC did that. Yeah.
I didn't realize news media were in favor of censorship again. I mean, it's new, that's news to me.
Yeah. Well, I'll tell you what, I'll speculate why, because NBC would get more clicks on an article that's politically polarizing than they would on one that's milquetoast facts. That's just how the media is paid. It's unfortunate. They're good people in a bad incentive model.
Yeah. I mean, it's a strange situation. You have a governor, you may like him or dislike him, but he's trying to like show you through this conversation what advice he's getting and the basis for the decisions he's making. That's good government, right? Like when you
transparently,
right, yeah. Right. So like again, you may disagree or agree, but now you know what the basis of his decision making, right? So, or at least some of the basis for decision making,
right?
Why would you censor that?
Yeah,
I don't understand. Like it's a misapplication of the public health norm.
That's exactly right. That public health norm, which says it's dangerous to dissent from what the messaging is, but this is not what that is. This is policy and science and decision makings based on not just what data we have, but what our values are, and looking at the big picture of cost versus benefit across multiple sectors, which is what you're trying to do when you influence policy.
Exactly.
I mean, heck, dude. Look, no matter what people think about whether you're right or wrong, you have to understand that the approach is correct. If there's something they disagree with in your approach, well, then they can criticize you and go, I don't like the fact that you go on Dr. Drew and say this. Like, oh, okay, fine, I'll take that criticism too. But the idea behind it, I think, is unimpeachable, but it's being impeached. That's the thing.
It's really strange. Yeah. Like if they have you said there was like some intern or whatever doing this, right?
Yeah.
Like if they maybe they have some algorithm, I don't know, to flag it.
I'm the victim of algorithms a lot. Yeah,
but okay, fine. But that's not the right norm, right? If you have a counter argument to make, YouTube essentially has editorial standards,
right?
And the editorial standards essentially say science can't happen here.
That's what's happening. Yeah.
Right. And so if they don't like what I said,
yeah,
and they have reasons, they say, Jay, you missed this study. Jay, you got the cost benefit analysis wrong. Jay, you did. I mean, that's good science.
Yeah. Contradicting
what I said with other science, and then we can now have a conversation and a discussion and a debate. It's the dialectic playing itself out.
Right.
But that's not what they do. They just say, look, what you said was dangerous. We're going to make sure the public doesn't see it.
It's nuts. I've said this many times. There's some crazy crap that comes my way, Jay. Like I'm sure you get your inbox full of stuff, crazy, but I get stuff. Can you debunk this? Can you debunk that? Can you debunk this? And I just take one look and I go, this is conspiracy level DEFCON 1 garbage. I would never dream of censoring it. Let it be out there and let whoever wants to debunk it. I'm not going to waste my time because I don't want to give them more platform and it's not big enough. But when something does get big enough, then I'll do a video and say, I think pandemic is wrong. This is not a thing, or, whatever it is. And that's how it ought to be done. And then you present your case and people can decide.
Yeah. I mean, the norm, let's take it out of science. Like the norm in American democracy has been, how do you counter bad speech? More good speech.
Good
right?
speech, yeah.
I mean, I think that norm ought to be. It's actually really a wise norm. Let's have that back.
Sam Harris has said this. When you start censoring speech, you remove our only ability to resolve disputes without violence.
Yeah.
Speech is how we do it.
And John Stuart Mill had this. I read it in like 5 million years ago, and it's still with me. Like if I'm wrong, and I say something wrong, well, I've done you a favor because I've given you a chance to refine your thinking about why I'm wrong. Mm-hmm. You've done me a favor by giving me good information that I might, potentially change my mind around. It's actually improved the entire conversation. Mm. The dialectic is a really valuable thing to arrive at something closer to the truth.
That's right. It's an iterative process. And you need other human beings, preferably in person, by the way, but if you have to do it by Zoom. I've done videos on why I think Zoom is there's actually data now on why it's less effective, especially in group collaborations, because we have two types of synchrony in, like you and I, we can see each other right now in person, and unlimited bandwidth, whatever, limited by consciousness, right? So it's consciousness limited bandwidth.
In my case, very limited by that.
Well, hey, both of us are primates barely out of the soup, but I'll say this. We can read each other's body language. We can make eye contact. We know when to take turns when we're talking, although I talk too much and I interrupt. And we synchronize our ability to exchange information. On Zoom, what happens is we get, according to this data, we're so focused on the visual cues that we ignore some of the subtle auditory cues and body language cues that allow us to not either dominate a conversation or be dominated and speak a turn, particularly in groups of more than two. And that's why the argument is turn off the video and just go to audio only, and it's more effective.
More like a phone call.
Yeah, it's kind of interesting. So again, these are the things we'll learn from this pandemic that will science this up and make us better, right? Because I don't want to sit in traffic again, Jay. I don't want to travel and do talks. It sucks. Like I like doing my talks from here.
Yeah, I mean, in some sense, that is something that we're going to get out. I mean, I think that ability to work away from home, at heffectively is something we have learned a lot about in the pandemic,
right?
For some professions,
telehealth a little bit too. I think,
that could be. That certainly could be. I mean, I think if we're honest, we'll do and science will be honest about this. Like what a full set of investigations, some of which will produce some good outcomes from the lockdown, much of which I think will produce bad outcomes.
Right.
But I think we need the full scope
to understand it. Yeah, exactly. And we need to, that means you can't have censorship. You have to have open dialogue and you have to assume good intent. I think that's another problem. I sometimes fall into this trap when I see one of these doom bait people online and they're like, well, the variants are going to kill us all. You know, like there's a particular person on Twitter, which we can talk about, not the person, but the behavior on Twitter that just, it's an epidemiologist. They'll take any opportunity to spin a very fearful monologue. And the question is, who is that helping? You know, if first of all, I think scientifically they're wrong, but let's say even they're correct. Is that the approach that's actually going to motivate behavior change? It's not. It's being honest and having a dialogue and understanding and actually even saying, well, there's multiple sides to this. On balance, I think this.
Yeah, I mean, I think. I was thinking about this. I don't. Okay, I'm a little bit hesitant to do this because I'm not sure I fully believe what I'm about to say. But I think they're kind of. You know, at Stanford we have this like fundamental standard. The fundamental standard is like a standard of how behavior that says how should we treat one another at Stanford, and it basically amounts to something like the golden rule, right? Which is a ubiquitous standard for a reason.
Yeah.
Twitter, I have in addition to arguing that academics and scientists on Twitter should adopt the golden rule when they're talking about other people, I think there's another rule I want to add to it. Don't say something you wouldn't say in a referee report. Right? Because that's the norm of scientific discussion and debate, right? It takes usually place behind closed doors, but actually I think it's healthy that it takes place outside closed doors, so the public can see it.
Yeah.
Because it's a good debate. It's a debate focused on facts and just disputes about how to interpret facts, pointing out of errors in fact. I mean, all kinds of things. I mean, which is annoying if you're trying to respond to them, but it's actually good for science, right?
Yeah.
That's the kind of debate I think a responsible scientist should seek out on Twitter.
Right. And so lacking the ad hominem attacks, lacking what bothers me a lot on Twitter, I think Vinay's talked about this too, is that you have a scientist who's advocating a very strong political position. Like they're vote for this candidate. I mean, more or less just putting it out there. And then the very next tweet is lock everything down or open everything up. And everyone who thinks otherwise is murdering grandma. And it's like, well, you've already poisoned the scientific discourse by openly politicizing it, ad hominem use, and violating the principles that you talked about. Yeah,
again, this is, I don't want to like moralize this because I don't think my particular approach may be not right for everyone, but like I've never donated any money to a political candidate because I don't feel comfortable. We're a political party. I just don't feel comfortable. I have to opine on health policy. I would like to reach all people, whatever their political, because I'm trying to find facts, and I've tried to convince people that these are facts that don't have nothing to do with my particular political beliefs, which frankly are not that interesting. I just don't care that much about politics. Yeah. I've never, frankly, before the Great Barrington Declaration, ever signed a petition before.
Yeah. You know, it's funny because petitions are like, the concept of it is just so off-putting to me. And yet there you did it because you believed in this idea.
Yeah. Now I've signed a couple. So like there's that, and there's a couple on like free academic freedom I've signed. But those are like, I have to tell you, like every time from Great Barrington on, every time I sign a petition, I'm like, okay, am I compromising my ability to persuade people about something, some fact I found?
Right. And I think that's a valid concern. I think you should have that concern always. You know, like in my profession, whatever that is, I call myself alt-middle. Like, and that doesn't mean I'm a centrist. It means that I have this radical, an unusual commitment
to piss everyone off.
To piss everybody off. Exactly.
Well done.
Exactly. To hear all the sides and make decisions and then present it in a way that isn't overtly. So if I'm politically biased in some way, I'll say, okay, here's my bias. Now you may disagree, and this is why.
Well, I don't mean to butter you up, but actually I've been watching a lot of your videos since we spoke, and I've watched a few before that. I mean, you're actually quite good at that. Like you're trying to reach people you wouldn't naturally agree with, right? I saw that. Like, and I think that's the right norm for scientists to have. We should aim at talking to everyone, regardless of politics. I mean, in some sense, like in the scientific discussion around COVID, especially in elite circles, there's been this like bigotry against Republicans.
Yeah.
And I think it's really been harmful both for scientists themselves, because now what you have is created a distrust of science by a large part of the population.
50%.
Because they correctly sense that you're bigoted against them.
Yeah.
Why would you do that if you're a scientist? It doesn't make any sense to me.
I agree so strongly about this because, and it doesn't matter what your politics are. It's a question of like, it's the dumbest move to polarize. And that's why I made that comment about scientists wearing their political beliefs on their sleeve on Twitter. I understand what Twitter rewards. It rewards politics and division. But by doing that, you've now alienated the other side of this thing. You're never going to convince them because they're going to brand you as an ideologue and somebody, and this is how we work as humans. We're emotionally invested in our beliefs, and whatever that tribal identity badge, if you violate it, for example, Jay, like if I were a far lefty, I could just go, I'm not even going to watch this show with Jay Bhattacharya because he's been associated with, dissent. He just said he did a thing with, the Florida governor who's a Republican.
You wouldn't write in a referee report an ad hominem attack.
Never.
Or guilt by association attack.
Right.
You would never. So that's one notch in favor of my. If you would you write it in a referee report rule?
Exactly. Or a mind reading fallacy where it's like, well, he clearly wants to poison old people. Like, okay, so you're in his head. I mean, it's true, but actually you're the opposite. You want to poison young people and protect old people. Oh my God. You're an ageist.
Yeah, I guess so.
Yeah. You know what? Time to cancel
actually, it's COVID that's the ageist. We should blame COVID.
You know what? All this time we've been trying to blame it. It's been xenophobic, blame it on China, blame it on a lab. No, COVID is racist.
It really
and
is.
Ageist.
Yes.
It's racist and ageist.
So are lockdowns, by the way.
So are way to bring it all full circle on that, man. You're right. Lockdowns are both racist. Why are they ageist?
Well, I think they harm the young differentially, I think.
Yeah, I think you're right. Yeah. And you're seeing this pent up thing with spring breaks and things that are happening. And okay, so actually that reminds me. Sweden, everybody's talking about Sweden. Then everybody was like, oh, Sweden, oh, see, they were wrong because the cases went up and the deaths went up with the big surge in the winter and so on. Now where are we sitting with Sweden?
I mean, if you look at the overall excess mortality rate, it's actually in line with European norms. Actually lower, I think, than the majority of European countries, something like that.
That's the data I saw. Yeah. Out of I think 26, they rank 19th lowest.
Yeah.
In excess mortality.
Well, and it makes sense, right? So they had a harm reduction approach.
Right.
And so they had better outcomes on non-COVID mortality.
Right.
Than other places that had a sort of COVID-only approach.
Let me repackage that. They had less ancillary damage resulting in death than other countries, and that may have even balanced if they had slightly higher COVID.
Yeah, COVID deaths are tragic, but so are non-COVID deaths. And public health is a broad thing for a reason. There's so many facets of human life, and that's why I always love public health. It's focused on the whole human being.
Right.
I think it's lost that to some extent the last year.
Yeah, no, I think you're right. And it's been it's been politicized, and you can there's plenty of blame to go on both sides of the aisle on that. But I'll say, the Swedish approach is not what people think. Oh, just wide open, and they didn't. No, they actually had voluntary restrictions. They had some limits on large gatherings. They kept schools open,
and they told older people who were vulnerable, you really should stay home.
Yeah.
Now the mistakes they made were mistakes, especially early in the epidemic in Stockholm. I mean, a lot of people got infected in the nursing homes in Stockholm in the early days. It was similar to the New York in some ways.
Right.
I mean, that was an enormous error.
Yeah, sending patients to the nursing
But that's an error of
homes.
focused protection. Like you have to do. So I don't think any country or any place got it perfect. Like take New Zealand. People hold that as an example.
Talk about New Zealand
success, right? So they've had 4 lockdowns since they declared zero COVID. They're relying on a vaccine that could not, in principle, have been developed in their own population.
Because they didn't have enough cases.
They didn't have enough cases, right? It's kind of like a beggar thy neighbor epidemiology policy.
I agree. It's kind of like they have all these weird advantages. They're geographically isolated. They were in the southern hemisphere.
This is like Martin Kulldorff says this. Like they were very clever. They located themselves in the southern hemisphere in the low COVID season.
Exactly right.
And they have only, they're smart to be an island so that they could like close the border very, very early in the course of their epidemic.
Yep.
So they could actually get to zero.
Yep. So they could do true suppression.
Yeah.
They could get to COVID zero, and if a case pops up, they stamp it out.
Find it. Like so that. See, if we knew that COVID was in the country, let's say we shut down the country in January,
right?
Maybe we could have got to zero.
Yeah.
We just didn't know. But by March, it was too late.
But then it would have taken constant vigilance because the rest of the world would not have done that.
Right.
But you're absolutely right. So when people hold up New Zealand, now what about the Asian countries, say Singapore, South Korea?
Yeah, I think like Japan and Singapore are true mysteries in some sense. So like first in Singapore, the outcomes are really unequal, right? So the Malaysian immigrants there have had COVID at very high rates.
Ah, interesting.
But like take Japan, like you have an older population, and yet the mortality rate, the IFR, is really low from COVID, even as the cases have gone up some, right? So it's a mystery, right? I think there has to have been some. It's not urban density, right? So like I've done some of the math around this. It's not because they're more like Tokyo is one of the most urban dense areas in the country, right? So it's.
I watch anime. I know. I mean, one monster can destroy a whole city instantly. Yeah.
Godzilla,
so dense.
Maybe Godzilla is protecting him. I don't know. I don't know. I mean, but like there has to have been some level of pre-existing immunity is my primary hypothesis. Right? I don't think we still know the answer to that. But that's my leading hypothesis at this point.
Right. Because they talk about their different policies. Closing, like paying bars.
They didn't close. They didn't have lockdowns. And they didn't. Now, of course, they had masks. That's true. But they've always had masks. That the flu, despite all the masking, never stopped. The flu still happened in Japan before.
Yeah.
The flu is gone in Japan.
Right.
This season.
Yeah.
But they didn't have a lockdown.
Yeah. Well, let me ask you this. So how effective then do you think are masks? In your intuition and looking at the data.
I think mask mandates are likely not all that effective.
Mandates.
Yes.
Right.
I'm still open on like mask used properly protecting. I think that's still possible.
Right. So like surgical mask or N95. N95, I imagine, is pretty effective.
I think in certain situations, so for instance, I'm very much was in favor. Like we wrote this in Great Barrington Declaration. We're in favor of masks, effective mask use in nursing home settings.
Sure. Yeah. That's a focused protection.
Yeah.
Because we know they work in those settings, in those closed.
Yeah. It's just, but as far as like mandates go, like we've had 80, 90% mask, like you do these surveys in the US and they say like 80%, 90% say they are wearing masks.
Right.
Now, how are they wearing them? Are they wearing them all the time? Are they wearing them effectively? That's really variable.
Yeah. And you look at the quality of the masks, it's all these garbagey.
Yeah. Well, I can pull out mine and it's not all that quality.
Yeah. But yours is a placebo.
Yes. But the thing is like the
because you're vaccinated.
Yeah, I'm vaccinated, of course. I think the problem is like you have these like mandates and you look and see the timing of the mandates versus like the trend in cases. I see no correlation there.
Yeah.
It just seems like it's noise.
Yeah.
And it's not surprising. The mandates I don't think they're inconsistently enforced. People don't really wear the mask properly. They don't wear it in the right settings. Like so and I think a lot of that will turn out to have been a lot of noise about nothing.
Right. Yeah, I think effective mask wearing does have an effect. I'm with you on the mandates. I feel like if you just give people information and individual businesses can make decisions, I mean, it's a free country. They can say, you can't enter without a mask, whatever. It does create a lot of conflict in the moral palette of different individuals.
Yeah, well, it's created this like more the sense of like, I'm protecting you by wearing it. So it's like created this like weird social division.
Right. It's a virtue signaling kind of apparatus, especially on Twitter.
That was an enormous mistake from public. Public health should seek to destigmatize disease, destigmatize behaviors around this.
Right.
And instead, we've created this stigma.
Yeah.
Like both like mask wearing, of course, in the division, but also like around COVID. Like if you got COVID, you're a failure.
Yeah, that's true. It's on you. It's on you.
Like I just don't. It's shocking to me. Like HIV, I thought we learned our lesson with HIV.
You don't do that. And Monica Gandhi talks a lot about that. The way we treat COVID, we've learned nothing from HIV. We've learned nothing from harm reduction.
Yeah.
You give people information. You let them make it. You don't shame them. You don't put a.
You give them compassion and treat them. I mean, as best you can. I mean, I don't understand how public health got to this point. I thought we made a lot of progress, but I guess not.
I blame social media because I like to, because it's my whipping boy, and it's probably 30% correct. And that so that then brings us to another interesting public health proposal, which is the vaccine passport. So, okay, I've talked about this. The video I did, I said, okay, here are the issues involved in vaccine passports on the pro and the con side. Here's what I think. And what I think, I said, I didn't take a strong stand on this, but I said, I think we should shut up about vaccine passports and just get everyone vaccinated. And then you don't have to worry about it because we're going to be back to normal, right? Now, what's your take on vaccine passports?
I mean, I think first they're definitely coercive, right? So essentially now I can go fly on an airplane, even before I got vaccinated, that was allowed. I could go to a restaurant as long as the restaurants were open. That was allowed. Now, if I have a vaccine passport implemented by airlines or by restaurants, I can't go unless I have this thing. So I'm basically being forced. And if I'm friends with somebody who's not vaccinated, I can't go to dinner with them. Right? Essentially, it's a coercive way to try to force people to be vaccinated.
So the argument that it's helping businesses to then fill their restaurants and so on, your argument would be just open the restaurant?
Just open the restaurant, right? Yeah. And ask people who are symptomatic not to come, right? I mean, for instance, like so, but
vaccinate everybody.
And vaccinate everybody, right? So, but then let's take that one more step. Well, if I'm being coerced into being vaccinated, my natural reaction, and I suspect a lot of people share this, is why are they trying to push this on me?
Yeah.
I'm gonna start like doubting what you have to say. Like,
exactly
why do you have to force me to take this thing if it's good for me?
Right.
Why not just tell people, look, it's good for you if under these situations.
Yeah.
Here's what the data are saying. Just be honest with people. Public health should seek to create trust in the population. And it's a two-way street. By trusting the population, you create trust in public health.
Right. Instead,
the vaccine passport severs that trust. It says, I'm going to force you to take this, even though I can't convince you it's good for you.
Yeah. It's billed as a carrot, but it's really a stick.
Yes.
Yeah, or a little mix of the both.
Yeah. Although I hate that metaphor is always funny because like I think of the donkey and the stick and whatever.
Yeah, the metaphor is in the eye of the metaphor. Yeah.
Anyway, so but I think that the vaccine passport idea is one of these ideas that it's a solution in search of a problem, and it actually can be dangerous because I think it creates vaccine hesitancy.
I'm not sure I disagree with you.
The other thing is just the inequality aspect of it. Like we have talked about the 120 million to 170 million people that have had already COVID.
Oh yeah.
Are we going to just say they're going to be forced to like?
You're preaching to the choir and the inequality.
This like two-tier society, vaccinated, not vaccinated. I thought we were done with that.
But we're not done with stratifying on income and age and so on.
Yeah, it's
in
the
a
poor
bad way.
that have had it more, right? So like we're going to exclude them from participating in normal human society. It just doesn't make sense.
Yeah, It's crazy. I mean, so what is going on in Michigan where you have a little vaccine penetrance? You think there's some semblance of herd immunity from natural infection. Is this just a case-demic like you thought earlier?
Well, I don't say it was case-demic earlier. I mean, I think, but I would say for Michigan, they've had a lockdown for a very long time. What lockdowns do is it delays when the vaccine, when the cases happen. I think the lockdown population maybe started to like come back. I haven't seen deaths rise as sharply as you would expect given the sharp case rise.
Right.
So maybe we're seeing decoupling of cases and deaths there.
Right. And we talked about it earlier, but I still am.
A case-demic would be nice. Like if you decouple, it is a case-demic.
If you decouple, yeah.
Yes. It's not a case-demic if it's not decoupled, right? So
that's right. Yeah, I was hoping that the winter surge would be a case-demic, and it wasn't. And with Michigan, that's interesting, this idea of lockdowns smearing. You bend the curve, so you are pushing it out, hopefully past vaccination, but the problem is the vaccination uptake is still quite...
Yeah, I think that wait until vaccination strategy, if that was the strategy from in March of last year, it's failed, right? The vaccine unfortunately came too late.
Right.
To protect large parts of the population.
Right. The most vulnerable parts. But it's still not too late to save lots of lives. Lots of lives, yeah.
Get the vaccine, stop the hesitancy, generate good trust in public health, and get the vaccine in people's arms, especially old people.
Yeah. What about kids, by the way? Kids and vaccines?
Of course, not tested yet.
Not tested yet.
So I can take the easy way out and just say I don't think so because it's not tested. I mean, I think the risk of harm from COVID is sufficiently low that my threshold for almost any vaccine-related harm would be, very sensitive.
Very sensitive, right?
Yeah. So, I think we should do a very careful cost-benefit analysis because I understand they're actually doing studies in kids.
They are.
With this,
so Pfizer reported that between 12 to 18, 100% efficacy. Why? Because they're already pretty resistant.
Yeah, but efficacy against infection, not against
right, because who's having death in that group?
They would never be able to power a study like that.
They would be able to power it. They'd have to have 1 billion kids, and then you'd have like 100 deaths and in the placebo group.
Yeah.
So it probably works. The question, like what you said, is, well, if their risk of COVID is quite small and they're not big spreaders, those are a couple assumptions, then you say, based on considerable data, but maybe not perfect data, but considerable data, then why would you vaccinate them even if there's a chance? I'll put this out there. Even if there's a chance they're going to miss 2 days of school because they have headache, fever, and muscle aches from the vaccine.
I think vaccines have this positive externality, right? So partly we say you should be vaccinated even if it's not quite good for you, not perfect.
Because the herd immunity
right?
component.
Yeah, because the herd immunity component. But generally, when we recommend that somebody gets vaccinated, it's good for you and for other people. We don't usually ask people to be vaccinated when it's not good for you on net.
Yes, yeah. It's a tough sell.
It really is.
Yeah.
Right. And you can understand why someone would be hesitant.
Right. Because you're assuming all the risk with no of the benefit.
Right. So
even if the risk is minuscule.
Exactly.
Yeah.
So I think that question of is it personally beneficial is really important.
That's what I tell people when they ask me, I'm 29 and I have this autoimmune condition and I'm worried about this and I read about that and I read about this and I go, hey, look, probably this vaccine is perfectly safe for you. However, if you have concerns, your risk of COVID is this. Yeah. So now you can make a decision based on what is important to you.
Right. I think we have to. I think that principle is really important to address vaccine hesitancy.
Right.
Like again, the individual. Ask your doctor, and that's what you always say. Like, go ask
your doctor about Lipitor.
Yeah.
Right. No, it's true. And a surefire way to vaccine hesitancy and anti-vax activism is an absolutist stance on those things.
Yeah.
And it's also not true. It's not how humans should work, especially with something that's a risk modulator like vaccines. I don't know that we'll ever really achieve a true herd immunity with this thing. I think what will happen is become endemic. And just,
herd immunity essentially is endemic. That's what it means. And the thing that's complicating about this is the herd immunity threshold is not a single number. It varies by season. It's definitely seasonality.
Yep.
And so you'll see like there's overshoot up past the herd immunity threshold because we didn't do a good job of slowing the spread or didn't protect people enough. And then as immunity declines, which it does over time, eventually you will hit the herd immunity threshold is coming back up in another season.
Right.
So it's you're going to end up with endemic equilibrium, which is
Yeah.
essentially herd immunity.
Essentially, right. So it's just by a different name. And I think what's interesting about that is I do speculate the coronaviruses that live with us that cause common colds probably caused a coronavirus-like syndrome.
I saw a paper on this on apparently there was a massive coronavirus outbreak in the late 19th century in Russia.
Interesting.
That had like this huge, and the theory is that of the four circulating coronaviruses, one of the four was introduced in the human population with this like mass death in Russia and eventually sort of filtering through.
It makes perfect sense. I mean, and there were reports, I think, right in the Native American population that they brought in common cold from Europe and just it decimated a good segment of that. Yeah. So people's initial naive immune response can be can be harmful in
bad,
itself. Yeah. So, but that's good news. So when people say that, because this is another thing that in messaging, this thing's going to be with us forever. Oh, well, that's miserable, but it's not, because that's exactly what a virus would do like this. You don't eradicate it like, polio or smallpox.
Yeah, which is why I think zero COVID is an insane fantasy, right? I mean, like, we have to learn to live with it. And I don't think it eventually will be all that bad.
Right. I agree with you. Yeah, I think it's going to be like, I got a cold. The nice thing is, with a large segment of the population vaccinated, it might actually, it might be less problematic as a year-to-year,
You may never need a booster, actually, because if you have some T cell immunity to this, which seems like the vaccines do,
enough to prevent death and hospitalization,
then you get the second, you get reinfected 2 years later, and it's much mild. It's a mild cold, right?
That's what that's the press hardly ever says. Oh, there's a reinfection. It's like, yeah, but. And how bad was it?
Yeah.
He had some aches and
I think all of the cases of reinfection where it's been severe, it's like there's some underlying immune deficiency.
Right. And in fact, there's some speculation that some of these variants emerged from immune deficient people who were getting like IV antibodies and so on. And so they were replicating virus, but they weren't getting the immune cascade that kills them. And these viruses were then allowed to select for variants. But, and again, this idea of variants, like, I think it's funny. I was talking to Paul Offit offline, and I don't think he'd mind me sharing this idea, but a virologist specialist, I mean, he is not, when the press reports about how variants are going to escape immunity from vaccines soon, he's like, no, that's really unlikely.
Yeah. I think, this thing mutates all the time. I mean, it's just, there's tens of thousands and maybe more mutations of this thing. And it's not surprising when you're nearing the end of an epidemic, actually, to have selective pressure to find, like, there's only the resources of the virus are other people that are uninfected and still susceptible. They're fighting so even viruses with mutations with very slight advantages in infectivity will take over.
Exactly right.
In many cases, that doesn't mean it's not going to explode again. It's still, as long as there's cross immunity across variants, which I think there is.
There is, yeah. And I think that's where there's people like this guy Gert von den Busch online who's been saying we shouldn't be vaccinating anybody because we're putting selective pressure on the virus.
Oh, I think I saw this.
You see this? Yeah.
I mean, I think that's not right. I mean,
no, it's wrong. Yeah. Now again, he's a guy who did a YouTube video and it went viral, and I got 1 million people send it to me. And he's a virologist and in Europe, and he's an outlier in what he believes compared to the rest of the community in which he's a member. You don't censor him.
No, of course not.
You don't turn him off.
You take him seriously.
And you address his issues. Right. Now, he may disagree that I've addressed his issues, but
that's science.
That's science. Yeah. Go make a louder video.
Yeah.
That's how everyone's like, you should debate him. I'm like, he needs to debate another virologist.
Yeah.
He doesn't need to debate ZDogg MD. Now
I'd pay for that.
Oh, I bet you would. Then we could be like like an old school cockfight where you have, the chickens are coming. Yeah, man. So what else is on your mind these days?
I think we've covered a lot.
We covered a lot.
Yeah. I mean, I think, I think we've got, I mean, maybe we can come back some other time.
Oh, anytime, dude. You have an open invite on this show. And it'd be good to do a post-mortem when this thing is over, which is going to be a couple weeks, right?
Could be.
I don't know it'll be that fast. To really go through and go, where were we right? Where were we wrong? What's the new data say? Because, this is going to happen again in probably less than 100 years.
Well, I think that's really important, actually. So I think there are lessons to be learned from this about pandemic management and the failures of pandemic management when we know there's going to be fear in the population.
Yeah.
So how do you create a process of developing good pandemic responses in the atmosphere of fear?
That is a great project, because the early days of this, man, the pall of fear that descended, when the Bay Area here went silent and there were no planes and there were no cars, and it was like 9/11, this just sense of dreadful awe that what is going on, and nobody knowing what the IFR was, and that fear really causes humans to behave in ways that
we're still not out of it.
No, it's if anything, some aspects of it are worse because we've conditioned it. So much anxiety and I have people yelling at me to stay away, like, in the elevator here in my own complex, and I'm wearing a mask and I'm vaccinated. It's like we've conditioned, and this is a young person. I keep telling this guy, I said these 2 young 20-year-olds wearing like hazmat suits on a plane, a flight I took to Hawaii. I'm like, what, dude, you don't need this. What are you doing? I mean, it looks cool, but not really. So anyways, man, this is what I appreciate about you, J-Bot. You're fearless, you're compassionate, you're rational. And whether you're right or wrong, you're probably right on some things. Maybe we'll learn that we're all wrong on other things. That doesn't matter. The idea is you're out there.
If I'm wrong, I want to know. I don't have any, sort of pride in that sense. Like but I think let's have this debate. Like it's just healthy, I think.
Yeah, I agree. And let's strip the politics and the emotion as much as we can out of it and just get down to brass tacks. Yep. Which is punching each other in the face when we disagree. I mean, that's how it went down, dog. I don't know about where you trained, but at UCSF, someone stepped to you and said, you know what? I think that gate receptor ion channel actually is a cation. And you're like, oh, you think so, huh? And then you slap them across the face with a latex glove. And then they have a latex allergy, and then you've killed them. So, I don't know where this went.
Somehow I see the Darth Vader mask on you when you're saying that.
Because that's when I'm channeling my id.
That's right.
It's a kind of a improv id. Like Vader can tell no lies. That's the thing about Doc Vader.
That's right.
He only tells the truth as the vehicle sees it in that moment. And sometimes that truth is painful. Sometimes it's offensive. Sometimes it's wrong, but he sees it as truth. So
it's hilarious. So there's
what can I say? Science. J-Bot. I don't know why I keep calling you J-Bot, because it's like,
I like that actually.
I kind of dig it too.
Yeah.
With 2 T's, because one is necessary but not sufficient. So, Jay Bhattacharya, professor of medicine at Stanford, health economist, and general superstar during the pandemic, and raising hackles on all sides, which is what I love, and speaking truth where truth needs to be spake. Thus spake J-Bat. Thanks for coming, man.
Thank you for having me.
And guys, we're getting canceled. I'm not going to be able to put ads on this video. There's money in the ghetto. As what was the rap group that said that? You don't strike me as a hardcore rapper. Yeah. Bottom line, become a supporter of the show, zdogmd.com/supporters, and you can put a tip in the tip jar, and I'll respond to your comment by PayPal, paypal.me/zdogmd. This is how I do ads. Like, instead of like, listen, guys, I have the perfect supplement that'll help your erectile dysfunction be 70% worse. All right, guys, I love you. Share the video. We are out. Peace. Thanks, man.